From the start of the pandemic, former FDA Commissioner Dr. Scott Gottlieb was in regular contact with key players in the Trump administration. And his new book, Uncontrolled Spread, Why COVID-19 Crushed Us and How We Can Defeat the Next Pandemic, details the mistakes that U.S. officials have made and may still be making in responding to the virus. Dr. Gottlieb is also a member of Pfizer's board of directors, and he's here for his first live interview about the new book, How COVID-19 Crushed Us and Why. I want to get to the book, but because you are on the board of Pfizer and we have this big Pfizer news, I want to get to that first. How soon could children under the age of 12 start receiving these vaccines?
So this data was in children 5 to 11 years old. It's a 10 microgram vaccine, so it's effectively the same vaccine that's being used in adults, but in a lower dose. Pfizer tested multiple doses to find the optimal dose that had the best compromise between reducing the number of vaccine-related side effects while still providing efficacy that's on par with what we saw in 16 to 25-year-olds. So this is basically 1/3 the dose that's already approved in adults. Now that they have the data, they could be ready to file this within days with the Food and Drug Administration. The FDA has said that the review of this vaccine, they've said publicly, is going to be a matter of weeks, not months. Now, having been at the agency, I interpret that to mean 4 to 6 weeks. So I think that there's a possibility you could have a vaccine as early as around Halloween. Maybe a little bit later, you might lose a week here or there. But I think that if things go well, if the FDA looks at this data and feels confident that it demonstrates that this vaccine is safe and effective for children 5 to 11, you could have a vaccine within a month to 6 weeks.
One of the compelling arguments in the book here is that our response to pandemics needs to be treated as a national security issue. With that in mind, as we look at an FDA panel declining to recommend booster shots for all Americans, do you think they're moving quickly enough?
Well, look, I think what they did was appropriate. They're going to take a staged response to trying to make boosters available to the American population. So what they said was 65 and above and people who are at risk of a severe outcome from COVID. That could be expanded and maybe even narrowed by the CDC once the CDC makes a recommendation based on the FDA's advice. But what I think you're going to see is public health regulators now collect more information to demonstrate that the vaccines might be effective in people of a younger age, and they'll start walking it down the age continuum. So I think that this is a start. I think they started with the population that's most at risk of breakthrough infections, which is the older population. They were vaccinated a long interval ago, and they also have the worst outcomes if they do contract COVID. So I think it's a prudent way to do this in a staged fashion, and I can see them now collecting more data and then walking this down the age continuum.
Yeah, I want to follow up on that in just a second, but to go back to the question about the kids, was there anything about side effects for children who get the booster?
So the profile in 5 to 11 looked on par with what we saw in 16 to 25-year-olds. Pfizer tested 3 different doses in children ages 5 to 11 to try to find the optimal dose that provided the same immune response in terms of the kind of antibody production that you were getting with the lowest possible reactogenicity. That's vaccine-related side effects like fevers and injection site reaction. The profile of the vaccine in 5 to 11 actually looked better than in 16-25 in terms of the antibody production and the side effect profile, but there was a real emphasis on trying to find a dose that was optimized insofar as it provided a sufficient immune response, but also the lowest possible reactogenicity. And actually, the immune response between the 10 microgram dose and the 20 microgram dose seemed comparable. And the reason the 10 microgram dose was chosen was because it seemed more tolerable in young kids.
You know, the FDA panel, when you look at Israel has said, listen, everybody needs to get the booster. It's 10 times more effective. And the FDA panel isn't there yet. Israel seems to be way ahead of us when it comes to fighting COVID. Why is that?
Well, look, they're moving more quickly. They basically got 50 experts in a room to come to a decision about making boosters available. We have a very iterative process here in the U.S. where multiple regulatory bodies weigh in on it. It's a slower process, and we also haven't been collecting data systematically looking at boosters in this country and also looking at breakthrough infections. The data we're relying on is the Israeli data. So I think that they were in a position to move more quickly and roll it out more quickly. We'll get there.
They're the size of an American state.
No doubt.
They're a country, but they're like New Jersey, basically.
No doubt. Your book examines what you call the failures of the CDC. What do you think the CDC got wrong, and what do you think they're still getting wrong?
Well, look, I think at the outset they didn't have the logistical capability to really roll out a response that was of the magnitude that was required. They didn't have the capability to handle a national level public health crisis. It's a very retrospective mindset at the CDC. They're a high science organization that does deep analytical work. They don't have a logistical capability, so they couldn't scale production of a test and distribution of a test early on That got us really behind. They couldn't scale production of a vaccine and actually roll it out to the public. They couldn't collect information in a real-time fashion and do analytical work to inform real-time decision-making. So, for example, for months, they were still recommending that people wipe down their groceries and had a presumption that a lot of the spread was through contaminated surfaces when, in fact, it wasn't. It was through aerosols. So it's deeply analytical. They would rather spend 4 months collecting rigorous data, doing analytical work, and come out with a definitive answer rather than surface real-time information that can inform current policy decision making.
You sound frustrated by that, Scott.
Well, it frustrated all of us. Look, there were a lot of things that felt very conflicting. The guidance on how far should you stand apart from someone to reduce your risk. Is it 6 feet? Is it 3 feet? Is it 10 feet? It kept changing. The initial recommendation put forward to the White House was actually for 10 feet of distance. They eventually revised it to 6 feet and then subsequently revised it to 3 feet. We could have done that a lot earlier. That was the single costliest advice that CDC gave because it forced many schools to stay closed because they couldn't provide for 6 feet of distance between students.
Now let's just get it right.
You called it arbitrary, which is not a word you want in association with health guidance.
No.
Dr. Scott Gottlieb, who will not be invited to the CDC holiday party this year, but has a lot of good information here in the book. It's called Uncontrolled Spread, and it goes on sale tomorrow. Dr. Gottlieb, thank you very much.
Thanks a lot.
Thank you so much. Eye-opening stuff in this book, indeed.